My name is Jesse Jansen and I'm part of the Sydney School of Public Health, but also a part of the Wiser Healthcare program to reduce overdiagnosis and overtreatment. And within that program, I belong to a group of behavioral scientists who focus specifically on communicating overdiagnosis and overtreatment. And some previous speakers have already alluded to the fact that these concepts are actually very unfamiliar to most people. They're counterintuitive, difficult to understand, emotionally charged, and decision-making around these areas are prone to different cognitive biases. And Ian Scott, who's here today, has written a paper about that, and it's a very interesting topic. And we try to get to the bottom of this, but we also try to come up with clever ways to communicate information about overdiagnosis and overtreatment. And I'm particularly interested in reducing inappropriate use of multiple medicines in older people through deprescribing and shared decision-making about deprescribing. So I do this work with a big group of collaborators, and a couple of them are in the audience today. And I just want to specifically mention my PhD student, Christy, who has done a lot of the work that I'm presenting. So, as you're probably all aware, when you start taking multiple medicines, there is an increased risk of side effects, adverse events, cognitive and physical impairment, hospitalizations. And there's more and more attention for this topic, not only in the academic literature, but also in mainstream media. And I just wanted to highlight one of the comments. I don't know if you can read it, but just to show how difficult it is to communicate about this issue. This comment says, I can't read it myself, but it's something along the lines of, this is written by a health economist. It would be a bit more credible if it was written by a medical person. So it's just one of those issues that's quite hard to bring across in a reliable and understandable way. So one of the processes that have been proposed as a way to reduce inappropriate use of multiple medicines is by using the process of deprescribing. And I most often define this as the systematic process of identifying and discontinuing or reducing the dose of medicines when harms outweigh benefits within the context of an individual patient's care goals, current level of functioning, life expectancy, values, and preferences. And several clinical deprescribing protocols have been published over the past couple of years. I just want to highlight this one that was developed by Ian Scott and the Australian Deprescribing Network here in Australia. And all of these protocols and frameworks and algorithms stress the importance of patient involvement in the process of deprescribing. However, it is much more difficult to have conversations about stopping medication rather than starting medicines. And so that's the area of research that I'm interested in. So what we did was we looked at the literature and we developed a shared decision-making framework to help with deprescribing decisions. And the first step, and I won't go into all the details because we also highlighted some of the challenges around each of these steps. So the first step of this shared decision-making framework is to create awareness that options exist around medicines and that you can actually have a say about your own medicines, including the option to stop or reduce them. And this is something that may be straightforward and obvious, but it's something that patients often aren't even aware of. The second step is to discuss the benefits and harms of medicines. And as Nola referred to before the lunch, we know from the literature that the focus usually is on benefits and harms are often not discussed. And this means that patients and clinicians alike tend to focus on the benefits, but not really on the harms. And the idea is that if you better inform people, then they might be less inclined to choose inappropriate or more invasive options. So the third step is to explore patients' preferences and goals and help them make a trade-off between benefits and harms in relation to their preferences. Finally, the last step would be to try and involve patients in the decision to the extent that they desire, and I will talk about that a bit more in a couple of slides. So what we also did was we conducted qualitative interviews with 30 older patients and their companions, and these patients were of varying levels of education, health, and they were taking a varying number of medicines. So this slide shows the summary of our results, and what we found was that the patients differed widely in terms of their attitudes to medicines, their openness to deprescribing, and their preference for involvement in decision-making. And we identified basically a typology of 3 different types of patients. The first group was very attached to their medicines and highly valued them. They had negative attitudes to deprescribing and a high trust in their doctor, and they preferred to be informed, so they wanted to receive information, but ultimately they were guided by their doctor in the decision-making. The second type was more ambivalent to their medicines. They valued the benefits, but also at the same time disliked the side effects and just the hassle of taking them. They were willing to consider deprescribing. They were more informed and aware of the options available to them. They tend to be more proactive and had a preference for involvement in decision-making. The last type didn't really think about their medicines much. They were mildly positive about the medicines, and they largely weren't aware that deprescribing might be an option for them. And this group preferred to defer their decision to either the clinician or their companion. So based on our framework and the qualitative research and what we found in the literature, we developed a medicine conversation guide, which is a tool that can help make shared decision-making, make shared decisions about medicines and deprescribing. And this is a one-page tool that has questions related to the patient's understanding of their general health, their decision-making preferences, what their health priorities are, their general health goals, but also their preferences around their medicines, their fear and their worries, and quite a few questions related to making a trade-off between benefits and harms of medicines. So we pilot tested this tool in the context of home medicine reviews with accredited pharmacists. And overall, the results were positive. So we observed the home medicine reviews, and we saw that the tool seemed to be particularly useful for patients who were taking lots of medicines and for patients who had limited understanding of their medicines. And pharmacists seemed to just integrate the tool in their usual, the flow of their usual HMR. The feedback we received was that the guide helped to talk about the patient's medicines in a more holistic way, so not just focusing on the medicines, but on the patient as a whole person. Some of the questions were too long, and that was similar feedback we received from the older patients. The older participants felt that it really benefited the discussion to talk about their health more generally and not focus specifically just on their medicines. And they were generally comfortable to respond to the questions. So just to sum all of this up, I think that what our research shows is that it's really important that communication and psychosocial issues are central to both the problem of overdiagnosis and overtreatment and the inappropriate use of tests and treatments. But these issues can be overcome with good communication and consumer and patient involvement in shared decisions. I think the qualitative results in particular highlight that we need to think about ways in which we can tailor our shared decision-making process to individual patient preferences, as we clearly demonstrated that patients differ greatly in terms of their attitudes, but also their willingness to, for example, deprescribe, and also in their preferences for involvement in the decision-making process. I think our tool in the pilot study, the results of our pilot study show that our shared decision-making tool could potentially be useful to support patients in the process of deprescribing as well as clinicians, but we need to do more rigorous evaluation of this tool in a proper randomized clinical trial, which we've applied for funding for, so fingers crossed. So that was it. Thanks very much.